Welcome to our final Canadian Heart Rhythm Society Allied Health webinar for 2016. It's Deborah Campbell here. Welcome everyone. It gives me great pleasure to introduce Jennifer Cruz, our guest speaker this afternoon, or this evening, depending on what time zone you're in. Jennifer is the nurse practitioner in the Cardiac Rhythm Service and an adjunct lecturer with the Faculty of Nursing at the University of Toronto. Along with Dr. Mangat, they spearheaded the development of the nurse practitioner-led AFib clinic within St. Michael's Hospital in 2009. In fact, it was the first AFib clinic in Ontario. She has co-led in the Nationwide Patient Education Initiative for the Canadian Cardiovascular Society and Heart and Stroke Foundation, focusing on atrial fibrillation. Her current project interests include a nationwide collaboration with nurses and MPs in AFib clinics to explore AFib clinic models across Canada and the development of a simplified checklist approach to evaluating and managing AFib patients, which she is presenting in this webinar this evening. Jennifer is truly an amazing healthcare professional. I'm privileged to know her, and a patient advocate who continually strives to standardize care of AFib patients nationally. On behalf of the Canadian Heart Rhythm Society Allied Health Group, we want to thank you, Jennifer, for taking time out of your busy schedule to share your knowledge and expertise with us this evening.
Good evening, everyone, and thank you, Deborah, for the introduction, and thank you for inviting me to present today. Just a reminder for the audience that there will also be questions and answers at the end of this presentation, so feel free to write the questions in the chat box, and we'll take it up at the end of the presentation. This is my disclosure. Boehringer Ingelheim is the sponsor of this research project I'm about to present. Our project team included myself, my co-lead, Dr. Paul Dorian, and our research coordinator, Sana Mariano. Without everyone on this list, this whole project would not be possible. So I would like to acknowledge everyone on this list who are represented from each clinic site. Also, several supporters of this project. Atrial fibrillation, or AF, affects at least 350,000 Canadians. At least 6% of the population over age 65 and older live with atrial fibrillation. AF is associated with increased morbidity and mortality rates with significant economic burden due to healthcare costs. Hospital admissions for AF have increased by 66% over the past 20 years due to the aging population and a rising prevalence of chronic heart disease. It is important to diagnose and manage symptoms of AF to decrease potential complications and improve patients' quality of life. Guideline adherence can lead to improved patient outcomes, and it plays an important impact on health systems globally. In fact, the European Heart Survey on AF showed that guideline adherence reduces morbidity and mortality of AF patients and reduces costs related to atrial fibrillation. Although multiple AF clinics have opened across Canada in the past 10 years, it is unclear whether these specialized clinics are meeting intended outcomes, as AF guideline interpretation still varies. Currently, there is no systematic quality improvement review of AF clinics in Canada on a national level that may help standardize clinician practices, improve patient outcomes, and systems of care. There are no resources or documentation available on models of AF care in outpatient clinics that systematically harmonize processes and content of care that improves patients' outcomes. variations amongst AF clinics have never been documented, and no statistics are available that analyzes care provided by AF clinics in Canada. Furthermore, there is a lack of generally agreed upon or guideline-recommended clinical assessment tool, and it is unclear whether clinicians are consistent in how to advise AF patients on specific items that are not discussed in the AF guidelines. Initial review of literature was conducted within Ovid database using search words atrial fibrillation in outpatient clinic between year 2000 to 2014, which yield 14 results, but only 2 are specific to outpatient AF clinic. Emochi and colleagues from the United States enrolled 100 patients in the study. 15 had emergency department visits, 4 hospitalized, no thromboembolic complications were noted. Therefore, they concluded that usage of the emergency department initiated AF clinic pathways with early follow-up in protocol-driven AF clinic was associated with low readmission rates, no thromboembolic complications at 90 days, improved quality of life, and high patient satisfaction. Hendricks and colleagues from Netherlands utilized chronic care model with a software program to ensure compliance, and there were 712 patients randomized to nurse-led versus usual care. They noted that there's cardiovascular death occurred in 1.1% in nurse-led care group versus 3.9% in the control group. Therefore, they concluded that cost-effectiveness analysis in the study demonstrated that a nurse-led integrated care approach will save costs and improve survival and quality of life, and is therefore cost-effective management strategy for patients with atrial fibrillation. A secondary search within PubMed with same search words and you're limited to having full text availability yield 172 results and only 4 related to AF clinics, but the first 2 were same as the previous result. Steinberg and colleagues from the United States included 300 outpatient practice settings in the ORBIT AF registry, and ORBIT stands for Outcomes Registry for Better Informed Treatment of Atrial Fibrillation, and it's a 2-year follow-up, currently at phase 4, and it's expected for completion in 2018. The ORBIT AF registry will provide valuable insights into the safety and effectiveness of novel oral anticoagulants used in AF in the community practice settings. Next is Tran and colleagues from the United States enrolled 71 patients in the study, with 17 patients who were hospitalized. 2 of these 17 hospitalized patients had ischemic stroke events. Therefore, they concluded that when compared to the published data in the existing literature, managing AF patients in specialty clinics reduces the incidence of AF-related hospitalizations and stroke. The third search inquiry in PubMed limiting AF clinics in Canada, which yield 50 results, but only 1 related to the inquiry. It was Gillis and colleagues from Calgary, Alberta included 330 patients referred to AF clinic, and they concluded that early assessment and patient education may reduce emergency department visits and hospitalizations for AF. And this experience suggests that nurse-clinician-based AF clinic may provide earlier access to medical care and may improve health outcomes in the long term. This brings us to the objective of this presentation, which is to outline an overview of the Nationwide Atrial Fibrillation Project, provide information on models of AF care, as well as national statistics and data on AF clinics across Canada, discuss the development of the Simplified Clinical Assessment Checklist in AF care, present results of the online survey outlining consensus of clinicians' advice to patients, and explore implications for clinical practice and future direction for knowledge translation. This nationwide initiative is part of a large quality improvement review to improve the care of patients with atrial fibrillation in outpatient AF clinics in Canada and will function as a knowledge translation strategy to inform clinical practice and provide resources for future implementation of AF clinics in Canada. The project timeframe took place between October 2014 to December 2015. The project was divided into 4 modules, and each module covers specific objectives as follows. Module 1 is successful identification of models of AF care to provide information to clinicians and healthcare leaders in planning new AF clinics. Module 2 is to provide documentation of national statistics and data on AF clinics across Canada. Module 3 is successful development of clinical assessment tool in AF care to facilitate a standardized assessment in AF care. And Module 4 is assess clinician consensus on how to advise patients on items not included in the AF guidelines. The initial step to move the project forward was the invitation of registered nurses and nurse practitioners to participate. RNs and NPs were selected since this is the most common allied health professional within all AF clinics in Canada besides usual care received from physicians. Contact information of each RNs and NPs were obtained from a network of colleagues with known AF specialty within general cardiology or electrophysiology. A total of 20 RNs and NPs were invited via email to participate. The goal was to obtain representation from each province with an established outpatient AF clinic or with a known AF specialty program. The details of the project was presented at the Canadian Cardiovascular Congress in Vancouver in October 2014. We clearly defined what atrial fibrillation clinic is, which is a clinic dedicated to care of patients with AF or atrial flutter, but not particularly to any specified therapy. It is a clinical setting whereby patients' care is streamlined following clinical protocols guided by practice guidelines and best practices care pathways, and personnel providing care is other than the usual care received from a physician, commonly a nurse or nurse practitioner or pharmacist. Here's a table to illustrate the participant information, including 14 participants from varying sites across Canada. 7 are nurses and 7 nurse practitioners. The sites represented by the participants are listed here. All are from outpatient clinic, but only 12 have a dedicated AF clinic. The 2 sites in the project that did not qualify as a dedicated AF clinic simply had an outpatient clinic with general arrhythmia clinic, including usual care from a physician, and the NP roles included both inpatient and outpatient population, but not specific to the AF population. Fourteen participants were asked to develop a care map to represent their own individual outpatient clinic to understand commonality and varying models of care across Canada. Information regarding number of clinic staff, total clinic hours, allotted time for new consult and follow-up, and a brief description of clinic staff responsibilities were included in each care map. In order to maintain anonymity of the participating sites, individual models were coded in no particular order. It was Site 1, Site 2, etc. up to Site 14. We analyzed each care map to identify commonalities and differences of the models to present the results. Here is a sample template provided to participants to maintain consistency of symbols used in the diagram. The care map of each of the 14 sites are available in the Appendix 1, which is at the end of this presentation for your reference. Now for Module 2, the method included the following. The survey content was developed by the whole nursing and nurse practitioner group during the initial meeting in Vancouver. We were able to obtain a pan-Canadian consensus on survey contents, including the following categories: process before visit, process during visit, patient education, outreach, which included collaboration between each clinics or department within the institution or outside the institution, clinical statistics, which gathers information about each individual clinic, and participant responses were obtained by conducting an online survey, and the results were then analyzed and reported. The method for Module 3 included the following. A previously published guideline-based clinical assessment checklist was updated, then piloted over a 6-week period in 14 outpatient AF clinics in Canada. Each site were asked to use at least 3 clinical assessment checklists with patients. An online survey with a dichotomous scale and free text comments was utilized to collect feedback on usability, assess satisfaction, and make revisions on the clinical assessment checklist. For Module 4, a second online survey was conducted using dichotomous scale, multiple choice questions, and free text comments. The results were analyzed to evaluate clinicians' advice to patients on self-care items such as caffeine and alcohol intake, exercise activity, stressful events, when to go to the emergency department, lifestyle changes, and other items collected in this survey included information on sleep apnea screening, patient education materials given to patients, websites to visit, and quality of life questionnaire that was collected. After analysis of the results, it was reported. After review of the Module 1 care maps, it appears that there are 5 models of AF care and 4 are specific to AF clinics. These models of AF care give information on common clinic staff and similar patient flow patterns as follows. Model 1 included clinic staff of both a registered nurse and a pharmacist who collaborate together with mostly an electrophysiologist and rarely a general cardiologist. In this model, patients may also be seen or referred only for patient education and not for clinical management of AF. For Model 2, it included clinic staff of either a registered nurse or nurse practitioner who collaborate with an electrophysiologist or a general cardiologist. In Model 3, it has specific referral only from the emergency department, and the clinic staff includes nurse practitioner or a registered nurse and a pharmacist who both collaborate with an electrophysiologist, a general cardiologist, or general internist. For Model 4, it included clinic staff of registered nurse, nurse practitioner, and a pharmacist who collaborate with an electrophysiologist. However, in Site 14, patients can also self-refer only for patient education. In Model 5, there's no established specialized AF clinic within the institution, as patients are seen by individual electrophysiologists' outpatient clinic. Clinic staff could include a nurse practitioner or EP fellow. However, the nurse practitioner role follows specific pre- and post-procedure patients or variable arrhythmia clinics, both in outpatient and inpatient settings. Other centers who would like to implement a new AF clinic in their own institutions can emulate any of the 4 models made available here. Now, moving on to Module 2, which gives us information on clinic data across Canada. I've only provided some of the information we collected for interest of time. As you can see, AF clinics receive between 3 up to 30 referrals per week, with a mean of at least 12.5 referrals per week. There's 43% who are referred also received phone discussion or advice prior to clinic consultation. And the 3 most common reasons for referrals include management of AF, ablation, and cardioversion. I find the information regarding elective wait time quite interesting here. It reports a range of 7 up to 167 days. That's from 1 week to over 5 months, or a median of 36 days, or that's just a little over a month. The long wait of over 5 months to see a specialist parallels the 2010 International Health Policy Survey, noting that Canada ranked lowest amongst 11 countries with at least 41% of Canadians reporting having to wait 2 months or more to see a specialist. In my opinion, it would be ideal for AF clinics to set benchmarks to aim for less than 2 months for elective consults to decrease overall wait time. However, there's a lot of other institutional resources that needs to be taken into account, and it's essential to evaluate each clinic's mandate, which may or may not be set in each site. Certainly, it appears that only 43% have reported having to meet specific mandate, including only 43% have time guaranteed to see patients from emergency department. There are clinical assessment tools that's also used in most AF clinics, noting at least 79%. And these tools may or may not be paralleled with the information recommended by the AF guidelines, since it's individually developed to suit each clinic processes and preferences. Other data collected outlined here are duration of clinic time for initial consultation, which is a mean of 58 minutes, and 32 minutes for follow-up. Most of the attending physician in AF clinics are electrophysiologists, which is reported 86% in the survey. There's 57% who reported having patients complete a quality of life questionnaire or symptom questions in clinic. Again, I find this quite interesting, as I thought it would be higher since AF therapy is based on symptoms. The mean follow-up post-ablation is 53 days, but there's quite a range between 7 to 91 days. And again, should we be setting specific parameters on when is it ideal to see post-op ablation patients, or should this be based on institutional resources versus based on known 3-month blanking period post-ablation? It's quite interesting. In this slide, there's been 93% who reported discharging patients from their clinics or transfer of care when patients are on stable medical therapy. Most of the transfers are transferred back to the family doctor, at least 93%. Yet many clinicians also approach me that it's very difficult to discharge patients from their AF clinics. The inability to discharge patients from their AF clinics increases the wait time to see the new referrals due to the lack of time slots. The most common advantage for patients seen in AF clinic is the education provided for patients. And there's a reported 100% of patients that receive education and 100% either before or during their clinic visit in a paper format. The average number of AF ablations noted here per year has been reported to be 93 plus minus 94. Now, the patient-related outcomes collected in clinic is quite interesting, since only 50% included gathering information on incidents of stroke or TIA. But I think there's underreporting that may be happening here that could be related to whether there's a database that's set in place in each clinic that collects the information. And many participants have reported not having a specific database that collects specific information in their clinic for patients. In terms of results of Module 3, a total of 75 clinical assessment checklists were evaluated. I mentioned 3 clinical assessment checklists per site, but that was the minimum. Other sites submitted 18 clinical assessment checklists. All the feedback was quite positive, including the following comments. Comprehensive, provides standardized approach based on AF guidelines. An excellent tool and rationale provided is much appreciated. Provides baseline elements in AF care. Very useful, especially to new clinicians. Ensures complete care of AF patients. Based on survey results, revisions were revised, and it finalized the clinical assessment checklist in AF care. Here's the features of the Simplified Clinical Assessment Checklist in AF care and baseline minimal data set was loaded with intentions that clinicians can tweak or add their own based on their own preference. The Simplified Clinical Assessment Checklist is systematically organized with important elements within 9 categories, including history of present illness, which included data fields such as first presentation of symptoms, duration, frequency of symptoms, when and how AF was diagnosed, and how it was treated, and so on. Other categories included cardiac history, other AF risk factors, other relevant past medical history, medication reconciliation and history, test results, physical exam, treatment plan, test and follow-up, and there's at least 35 data points with rationale in each data field that was collected. The full document of this checklist is made available in Appendix 2 of this end of this presentation for your reference. The results of Module 4, which is the consensus evaluation, included 79% participants. That's 11 out of 14 clinicians had varying advice to patients, which means only 3 out of 14 clinicians were consistent in giving advice to patients regarding self-care items. In 4 out of 6 items, there's variations in clinicians' advice to patients. The 2 items where there's 57% consistent recommendations included advice on when to go to the emergency department and lifestyle changes in maintaining a healthy weight. Here's just a graphic representation of the results. As you can see, advice on amount of coffee intake, alcohol intake, amount of exercise activity, stressful events were all variable, whereas advice when to go to the emergency department and lifestyle changes were consistent. Other items collected including screening of sleep apnea, common websites to visit, whether quality of life questionnaire were collected, and which one was commonly used. The CCS-SAF class scale was used by the majority, while others just stated actual symptoms, no scales were used. One particular clinic noted a scale was not helpful due to inconsistencies in clinicians' interpretation, but care recommendation was quite consistent. I found this quite particularly interesting since use of scale was highlighted and recommended in the AF guidelines. Other items collected include whether the sites routinely complete quality of life questionnaire, which noted 60% of the sites indicated routine completion. This quality improvement review has implications to clinical practice. Firstly, the Simplified Clinical Assessment Checklist has been piloted over a 6-week period, and it's a tool that can be utilized to assess care of AF patients. This tool has all the components of guideline-based care which can improve outcomes. Although only minimal data set are collected, clinicians have the option to add more than the baseline intake. The information collected in the whole project helps us recognize that evidence-based continuing education and strict guidelines adherence amongst clinicians facilitates consistency in practice, including the advice we give to patients. Additionally, this unique project provides an opportunity to enhance AF care on a national level by fostering collaborative relationships amongst nurses in AF clinics. In fact, the participants of this project formulated an interest group called CAFNA, which is the Canadian AF Clinic Nursing Alliance, which promotes leadership and research within the nursing profession, also feasibility to share resources amongst each other to improve clinical practice that may translate into improved patient outcomes. A proposal to joining CHRS as a subspecialty group has been discussed and pending approval, which will facilitate more knowledge translation initiatives in the future focusing on AF care. In conclusion, this project identified 5 models of AF care across Canada, 4 of which are specific to AF clinics. By documenting the variations and commonalities amongst AF clinics, this provides information on national statistics. By virtue of knowing how everyone is doing, it helps us recognize our own clinic practices, which may translate into better outcomes to keep up with the norm. While AF guidelines are available, there's still variable recommendations amongst clinicians for AF management, and discussion in next AF guidelines update regarding specific recommendations on self-care items that are currently not discussed in AF guidelines can help find consistency in practice. Although the Simplified Clinical Assessment Checklist in AF care have been developed, validation of this tool can help facilitate a standardized assessment tool to improve patient outcomes. However, further research still needed to evaluate the effectiveness of using a validated clinical assessment tool on patient-related outcomes in patients with atrial fibrillation. So for this portion of the presentation, I would like to open some dialogue, discussion, and questions that I can answer. How can we improve systems of care, knowing what we know about AF clinics that's been presented here? Some questions I would like to ask the group, if you may like to participate. Would you consider using a standardized guideline-based clinical assessment checklist in practice, and is this realistic or practical? I don't know if there's any comments from the audience. How about, should we think about setting specific mandates in AF clinics to decrease wait lists to see specialists, since early treatment of AF care can actually decrease AF burden that's related to AF-related complications? Some things to think about. Or do you think there should be some sort of AF clinic registry to allow ongoing data gathering and statistics tracking for AF clinics? I just wondered if there's any questions from the audience. You can actually type in if you have any questions. Otherwise, I'll go through some of the appendix that I've included here. I'm not going to go through all of them, but I'm just going to just show you some of the appendixes that's been included in this presentation, and this is all for your reference. You can pause if you like for your future reference. When you go into the website, you can actually download this whole presentation. It will be made available in the CHRS website for the webinar archives. Here's Appendix 2, which just included the clinical assessment checklist. Again, for your reference. If you would like to contact me, here is my contact information. I just have a couple of comments, whether there would be validated clinical assessment checklist that would be interesting if it's translated in French and English. Yes, that would be great if we could. Thank you for your attention. Is there any other questions in the audience? I think that will be the end of the presentation.